Hello, everyone, and welcome to our Shockwave sponsored event. During the session, we will have our physician speakers present while you are in listen mode. While they are speaking, we ask that you raise your hand, comment in the Q&A, or wait until the end. We ask that you refrain from off-label discussion. If something comes up, we are happy to put you in touch with the physician speakers directly or our medical affairs team. At this point, I'd like to introduce our host, Dr. Chadi Alraies. Dr. Alraies is the Director of Interventional Cardiology Research at Detroit Medical Center. And our guest speaker, Dr. Raj Tayal. Dr. Tayal is the Director of the Structural Heart Disease Program at St. Michael's Medical Center. Today, they have agreed to share their experience using IVL. Dr. Alraies, please go ahead.
Thank you, Melissa, so much. I would like to thank Shockwave IVL for the opportunity to put this program together, and especially in the time when COVID-19 kind of hit since February, March of 2020, we have significant cancellation of all face-to-face meetings. So we've identified a knowledge gap and also important didactic sessions that are not present anymore because of COVID-19 and social distancing and other protocols. Therefore, I really appreciate the opportunity for Shockwave for believing in that initiative and for putting this series together. Case in point, where we're going to be focusing on technical aspects for challenging cases and the peripheral artery disease. With that, I would like to thank Dr. Raj Tayal for joining us today, who has been a tremendous expert in large bore vascular access, femoral and alternative, but also have been one of the experts and Shockwave IVL users, and have been proctoring across the country about the device and how to facilitate single access as well as go femoral and stay femoral for large bore access for structural heart as well as mechanical circulatory support. Raj, thank you so much for being here, and we look forward to hearing your case. And during the case, please feel free to ask any question to Melissa, and we'll be entertaining those throughout the case. Raj, it's all yours now.
Great, thank you, Shadi. So I'm going to start off and present a few cases, and then hopefully we can have a step-by-step discussion. And it's meant to be as interactive as we can be in this day and age. So please feel free to share your comments, questions, and we'll go through this step-by-step together. Just pull up my... So it's a pleasure to be with everyone today. As Melissa had been kind enough to introduce me, I'm the Director of the Structural Heart Disease Program at St. Michael's Medical Center. I also work with the RWJ Barnabas Health System in Newark, Beth Israel. So I'm going to present a few cases, the first of which is a patient that was referred to us for transcatheter valve replacement. She's a 78-year-old female who's relatively frail, known to have severe AS with moderate AI. She came in hospitalized with acute decompensated heart failure, was intubated and subsequently extubated. However, still kind of hard and unable to be discharged. She had a moderately reduced left ventricular systolic ejection fraction with an EF around 35 to 40%. She's known to have a history of coronary disease in addition to peripheral arterial disease with prior stent placement in the right iliac. She was also known to have a bilateral disease kind of diffusely throughout in being on dialysis for several years. A CT scan was done in preliminary workup and evaluation for a routine transcatheter valve replacement. And what we actually found is that the stent in the right iliac was actually protruding somewhat into the aorta. It was somewhat undersized, and there was a moderate degree of calcification, both in the right iliac as well as throughout the left iliac and in both common femoral arteries. This kind of limits the traditional up and over treatment strategy that sometimes is favorable with IVL if you're going to treat the contralateral common femoral. We also found that she had significant disease in the infrarenal aorta, which limited a cable approach, as well as the ostial subclavians bilaterally. Her aorta was diffusely diseased, so there was really no options even for a TAO approach. We felt like she was too ill and somewhat frail to really benefit or do well with a transapical approach. I think the other important point is that despite the availability and relative facility of a lot of these other alternative access techniques, there is data out that suggests that each of these is kind of associated with their own caveats, whether it be elevated stroke events or increased bleeding events. So looking at her CT scan, what you can see is all throughout the aorta, she's got relatively diffuse disease. You can see the stent protruding into the aorta, into the mid portion of it actually from the common iliac. And then diffuse disease, which is eccentric at points, but concentric in some, throughout the right into the right common femoral artery, which was in relatively small caliber, and then as well as in the left common femoral and throughout the iliac with a very, 360 degrees of pretty heavy calcium in the iliac vessel on the left. Again, looking throughout the subclavian vasculature, looking at all the other alternative access points, there really weren't a lot of great options for someone in this situation. So taking that into consideration.
Yeah, Raj, I would like to ask you about picking the size, or at least from your experience, when you have a ring of calcium like this, like 360 calcification we see there in the common iliac on the left, compared to eccentric on the right, would you have a preference? Let's assume this is a normal lumen that's accommodate the 14 or 16 French for TAVR. Which lumen would you prefer or amenable to therapy with IVL, Shockwave IVL?
You know, that's a fantastic question. And I think really the answer is both are very, very amenable to being treated. And I think it's somewhat a misconception that you need to have, concentric calcium. Eccentric tends to work as well. It just depends on how well the balloon is opposed, and really the sizing becomes the most critical matter there. Most commonly when we're looking to facilitate large bore access, we're looking to use at least 7 by 60 balloons in most instances. Occasionally we'll undersize it if we're going to treat the common femoral and come down to around 6 millimeters. But most commonly I'll start even with the 7 because again, the balloon in this situation is not meant as a primary angioplasty mechanism. It's meant as a means to facilitate the delivery of energy. So really having good apposition with the intimal wall is the most important fundamental factor to make this successful. And even if you are oversized, I think it's key to understand that you're only going to 2 to 4 atmospheres. So the chances of creating any iatrogenic injury are very, very, very minimal, even if you are oversized, as I'll show you in just a second.
Great.
So given all this in our relative facility with doing alternative access, as you know, percutaneous axillary access has been something that I've been doing quite frequently since 2012. And really been a big proponent of, although the data kind of suggests that the stroke rates are very, very high and somewhat unacceptably so when you look at transcatheter valve data and the TVT registry. These things range between 5.6 and 7%. So I think further investigation is certainly warranted in this area. What we have done is we've done a fair number of endovascular procedures from an axillary access point, whether that's treating the aortoiliac bifurcation or treating into the common femoral. And we've had no neurological events in that regard. So we feel very, very comfortable using 7, 8 French access points from this approach. So what we did for this patient is here you can see on the left, I've obtained micropuncture access in the left axillary artery. And then we subsequently upsized that to a 7 French sheath and took an angiogram. And again, you can see there's diffuse disease throughout the vessel. She's got a stent in the axillary vein. But there's diffuse disease in the ostium of the subclavian, which really doesn't make it very favorable for any form of large bore access in this area. However, it's certainly accommodative of at least a 6 or 7 French sheath. So after we've obtained our access point in the left axillary artery, what we then did is took a JR4 diagnostic catheter and then repositioned ourselves going down into the descending aorta, and then took a selective angiogram of the left iliac vessel. And again, you can see diffuse chunks of calcification. I can play that again just so you can see it. Again, in the ostium, throughout the common, at the origin of at the bifurcation of the external iliac and internal iliac, and then especially heavily dense calcification all throughout the common femoral. And particularly just above the bifurcation of the profunda and the superficial femoral artery. So from there, we basically advanced a 300 centimeter 014 wire and advanced that. With some difficulty, we actually directed it into the profunda in this instance because there was a subtotal occlusion of the SFA, and we didn't want to mess around too much with that, but we basically wanted to have a wire down to provide some bailout and protective mechanisms here. So over this 014 wire, we then advanced our IVL balloon after we walked the JR4 catheter out. So you can see that we've now have our 014 wire down into the profunda, and we've positioned the 7x60 IVL catheter directly throughout the common femoral. Now, if you're—
I'd like just to pause here for a second. So what is your workhorse wire? It's 014 for all Shockwave, but do you have a preference for a specific wire to deliver the balloons?
So it really depends on what you're doing and where it is, right? In this instance, because we were in the hybrid OR, our equipment is somewhat limited in terms of the number of wires, things that we have available. So this actually was just a regular 014 BMW wire, which was actually supportive enough to get the job done. You know, if I have my preference, I like to have a little more supportive wires, so something like a Grand Slam or a BHW as opposed to a BMW. There are a myriad of wires that don't really have necessarily heavy or hydrophilic tips, but you want a moderate bodied wire to kind of support this, as it is a little bit bulky in being a peripheral balloon.
And just another question, maybe we can come across it from audience, is about sizing of the balloon. You said 7/0x60. In terms of sheath size, did you place a 7 or 8 in the axillary?
So we put a 7 French sheath in the axillary, just a regular 7 French short sheath. You can theoretically do this through a 6 French sheath.
Right.
The reason that we opted for axillary access is because the catheter length is 110 centimeters. So the ability to reach the common femoral, even from the left brachial or left radial, is somewhat limited in that regard.
Correct.
They are relatively small, so we opted to do that in order to have enough reach and treat the area effectively.
Right. And just for your point, as you said, for the Shockwave IVL 6.5 and 7.0 go through 7 French, or recommended to go through 7 French. But as you said, we have good cases through 6 French as well.
Right. And, you know, sometimes I think if access is somewhat limited, certainly doing 6 French access and pushing the balloons through is fine. When you pull it back, there is a tendency for it to pull on the wire as well. So if wire position is important in maintaining that, it's something just to be cognizant of. The other thing that we've learned from our experience, as I'm showing in this case, is I would really advocate and urge people to use an up and over strategy if you're attempting to treat the common femoral. From what I've seen is a lot of people will attempt to, you know, gain access and then shock on the way up, meaning they'll get access, let's say in the left, and then shock, you know, just proximal to where the sheath ends. And what ends up happening is they're not treating that area of calcification where the access point is. So again, you're still leaving yourself pretty exposed to having some degree of sections or perforations at the access point itself.
Exactly. Yeah. Great.
So after we've done this, we started inflating the balloon and delivering therapy. And it's interesting because, you know, this does create vapor bubbles, which you can kind of see mixed here as the balloon is working, as we're deploying and providing the pulses. I think one of the other things that I see quite frequently is that people have a tendency to just do therapy once, twice, or 3 times, and then kind of move on and say, oh, that's good enough. The balloon looks great. I think it's very, very important to recognize that the more therapy is delivered, the more fractures actually occur in the calcium, and the more the vessel is allowed to expand, and the less degree of vessel recoil you'll experience afterwards. So what we did here is we continue to provide pulses of therapy. We're slightly moving the balloon, both distal as well as proximal. Not everything was captured under fluorostore or you know, direct cine in order to save some radiation and exposure. But basically, if you move the balloon around in the emitters, the maximum point of therapy is going to be the central emitter of the device. So really focusing that on the most heavily calcified portions is a very good point. The other point that I'd like to point out is that the tips of the balloon are not the same as a traditional angioplasty balloon. So making sure that you have adequate balloon overlap between the treated segments is very, very important in terms of, you know, optimizing best outcomes.
Right, and for the delivering therapy, what atmosphere are you at this point when you start treating?
So it depends on how aggressive or not. If you look at the IFU, a lot of people, it's basically you're supposed to go to 4 atmospheres, provide the therapy, which is 30 pulses, and then deflate, inflate it back up to 6 atmospheres to ensure complete expansion, then deflate for 10 seconds, and then repeat the cycle. Here, what we did, because again, this is a 7 millimeter balloon, excuse me, and about a 5.8 millimeter common femoral, is we went to 2 atmospheres as our initial round of therapy, and then just ensured and kind of took our time to really kind of provide the therapy and let that do it more than worrying about inflating it fully.
And this is a very good point, Raj. I mean, I learned this trick recently, and as you said, 2 millimeters is enough to take the balloon away from the emitter, so it doesn't cause any damage to the balloon itself. But at the same time, it's not too much aggressive to hurt the calcium as you are expanding. So 2 and then 4, and then if you want to go back to 6, up to 6 later on when you are having good therapy. Yeah, that's great technique.
Great. So we kind of sequentially treated the entire vessel, and then you can slowly but surely see improvement in the expansion of the balloon with the waist kind of resolving. And that's not with balloon angioplasty. That's actually just with the therapy itself occurring, and we're watching this under fluoro. So as you can see, the balloon is now starting to expand completely.
Nice. It's very nice.
So then we go on from treating the common femoral and move into the iliac, and you can see there's significant disease throughout the iliac. And multiple points throughout this case, our surgeon commented that there was no way that this was going to work and we would have to bring her back. But I think as we started providing therapy, like most people, you start saying, wow, this is really working and it's actually going to work, which obviously it did. So, which is why I'm showing it to everybody.
Yeah. And Raj, you highlighted a very important point in terms of the distance of overlapping between each therapy. It's based on the character of the balloon. That's a very important point. And to the audience, it delivers 30 pulses for 7 O's. Therefore, 30 pulses or 1 pulse per second for a total of 30 for 1 treatment.
That's exactly right. And, yesterday, one of the clinicals made a comment that it's like buying a beer. You're going to finish the whole thing. So as opposed to leaving half of it in the glass, you might as well use all the therapy that's available.
Right.
So 200 pulses, we treated that entire iliofemoral segment thoroughly and rounded out the entire segment.
You have it, just use it, yeah?
Exactly. So
Hi guys, we have a question real quick. Do you have a preference of French size and ATM pressure based on calcium angle location?
So,
Want to take that, Raj?
Sure. I like having more space. So I think if you have the ability to have 7 French access, it's favorable when you're using the larger balloons, although it's not absolutely necessary. I don't know if the degree of calcification necessarily plays directly a role in sheath sizing, unless you're concerned about the access point being a very, very diseased segment. In that instance, certainly using a 6 French, delivering therapy, and then upsizing it afterwards if need be is not unreasonable. But I really like to have what you need up front and not exchange it too many times if possible.
That's to your point. You agree. This is our approach as well. For below knee, you can get away with 5, but anything above the knee, 6 is preferred. But you're gonna have hard time puffing around the sheath if you can take a puff when you are done treating. Therefore, if you really do iliac work, iliofemoral work, I think recommendation for 7. But the calcium does not dictate the size of the sheath.
And the other comment I'd like to make is because you are working over an 014 wire. Mm-hmm. Exchanging out or upsizing to a larger sheath becomes a little bit more of a process than if you were working over a traditional 035 wire. So that's why I typically say just start with the sheath that you think you'll be able to fit in comfortably,
right.
If that makes sense.
And also help you for bailout strategy in case something happened.
Of course. Which, in interventional cardiology, we've progressed tremendously. But I think one of the key points in doing anything is being confident and having the ability to safely bail yourself out of any trouble that you get into. So for the duration of this case, what we did is, although it's not a very supportive wire, we did leave this 014 wire in place as a bailout mechanism throughout the entirety of the case, so that if we had to come up, and I'll show you how we did dry closure and whatnot at the end of this, but you always want to have some steps in place so that if anything does happen, you're prepared to act immediately as opposed to kind of taking steps to catch up. So this is basically us looking, I don't know if you can see our ultrasound probe in this image or not, but you can see there's a lot of calcium all throughout the iliofemoral segment still. However, under ultrasound, we identified one of the least calcified segments where we saw some fractures in the calcium. So we obtained access right at the pelvic brim here. And then, unlike we normally do, I did use a dilator in this scenario just to watch it go up and make sure it was going relatively resistance-free. So that was able to be advanced without any issue whatsoever.
So you had your 014 wire antegrade, and retrograde you put your micropuncture sheath and the dilators over it.
Yeah, and you know, in this case, I'll show you something that I really think is worth noting. You know, in some people that have PAD, I usually feel more comfortable with a single perclose because the team that was with me felt really strongly about having two percloses in place. In the event that one failed, we did go with a double perclose technique. There is a relatively high incidence of having a quote unquote perclose pinch in that scenario. So I'm more akin to using one perclose and then transitioning to a hybrid closure, where after you've deployed one, if there's still some residual extravasation, you can simply re-advance a 6 French sheath, which I'll show you in a second, and decide whether you want to put an additional perclose, an angioseal, a minx, whatever it be. But we'll go through that in just a second. I do want to show you how easily this 14 French valve, after we've treated the segment, just goes straight through.
Beautiful. Nice.
It just sails right through there. And that's without adding protocol or doing anything like that. And then from there, we have our standard valve delivery. You can see your lucent line here, which we're going to meet at the annulus here and get a nice valve positioning at 90-10.
How big is the valve, Raj?
6mm valve. And so afterwards, what we've done is we've, you know, withdrawn the sheath, and we have a 8x40 balloon down over that 014 wire. So this is a standard peripheral balloon that, you know, the difference between a peripheral balloon and an IVL balloon is the IVL balloon is specifically designed for the 014 wire. With a regular peripheral balloon, these are typically 035 compatible. So the benefit of working on an 014 wire in this scenario is then you can hook a TUI up to the end of the balloon and actually use it to perform your final angiogram. So we use this after we've removed the large sheath. We then inflate the balloon, remove it, and we took an angiogram. And as you can see here, there's a little bit of a cinch where the percloses were deployed at the end of it. The flow was brisk. We looked at all the flow down the leg, and it was completely unchanged. So we felt very, very comfortable, and the patient actually was discharged the next day without any adverse events or issues.
I would like also to applaud you and highlight the importance of ultrasound guidance, because if you can see there, it's like you hit it exactly where you didn't see any calcium on dry fluoro. And this is, you cannot do that without ultrasound. So it's always key for any large bore access.
Exactly. So I'll show you one more case, Chadi, and then we'll move on, and perhaps you can share a case after that. So this is a case where we used IVL to facilitate mechanical circulatory support. So for some of you, I had shown this at TCT, but this is a 76-year-old gentleman who had a myriad of multiple medical problems, had a recent bilateral femoral popliteal bypass, was on dialysis, poorly controlled diabetic, who presented to an outside medical center with a non-ST segment myocardial infarction and borderline cardiogenic shock. At that center, he was found to have multivessel coronary artery disease. I'll show you his baseline coronary angiography. In addition to that, he was noted to have severe aortic stenosis, severe mitral regurgitation, an EF of 25%, and sent to us urgently for a surgical evaluation. Clearly, because of his comorbid conditions and his clinical state, he was declined for surgical intervention and referred to us in this setting. So I'll show you kind of his baseline angiography. Because he was sent for CT surgical evaluation, we were lucky enough to get a quick CT scan ahead of time, so I'll be able to show you some of his underlying anatomy as well. So this was the baseline cardiac catheterization at the outside institution. You can see the operator was able to get femoral access. However, there's a significant degree of disease all throughout the common femoral, as well as in the superficial and below. There's also a lot of disease in the iliac, which is kind of hard to appreciate in this image, but I'll show you others that will confirm that. On the diagnostic angiogram, you can see, although not clearly in this image, I'll show you a better one. There's a heavily calcified lesion in the distal left main into the origin and ostium of the left anterior descending artery. And there's also, let's see. You can see it a little bit better here. And it kind of comes right into the bifurcation in that view. And then there's also a very heavily calcified lesion right here in the right coronary artery and in the proximal right coronary. These are his echocardiographic images. Again, you can see the EAS is significant. He's got a significant degree of mitral annular calcification, as well as a very real amount of mitral regurgitation. And again, just a short axis view showing us how much calcification is on the aortic valve.
It's barely opening up.
So this is a CT scan, and you can see that he's basically got lead pipes all the way throughout. You know, there's 360 degrees to 270 degrees of calcium, very big boulders all throughout. Again, really limiting our access options. The scan actually did not go all the way up to the level of the subclavians, but we were able to just ultrasound them quickly like we routinely do. And there's diffuse disease kind of throughout the axillaries. You know, he had dialysis access on the right. So although it's not a direct contraindication, it's less than desirable in a lot of settings, particularly if you're not sure if it's going to stay in place in terms of support and how long you're going to need it. So you can see he's not got the prettiest groins. There's clearly some very large scars that are suboptimally healed, but you know, sometimes you have to take what you can get. We always advocate for the use of ultrasound, except sometimes you don't really need it. You can actually see the entire outline of his iliofemoral segments, and you can see my micropuncture needle actually bending and moving the entire vessel back and forth as I'm trying to get access. We were able to do that, after which we secured it with a 6 French sheath. Someone had asked previously about using 6 versus 7. In this instance, because the vessel was diseased, it was relatively small in caliber. We did just proceed with a 6 French sheath prior to providing therapy.
Raj, let me ask you this. You are a large bore expert. Is it routinely, or how often do you use the 4 French Cook sheath just to take a test, make sure in a good spot before you upsize into a bigger 6 or 7 sheath?
Every single time.
Always what? Almost none?
Every single time.
Every single time. Nice. Yeah, okay. Because I feel like it's underutilized, and I feel sometimes in practice when they see these calcified arteries, they have the urge to use a Cook needle because they feel like when it get through faster or easier. But I think that's a technique you use, micropuncture and also 4 French, take a puff and then upgrade, maybe safer.
Absolutely. And I do want to point out, I think there is a little bit of a learning curve associated with using a micropuncture. You know, people complain about the wire being friable or, you know, buckling quite frequently. It's a very kind of feel associated wire, so it's very quick to give you feedback. You know, at points you'll be able to tell if you have ridden into the circumflex or whether you're actually in the true, you know, main branch of the vessel. It's important to kind of become familiar with that. And recognize that a lot of times when you are getting buckling of the wire, you're not in the true intima of the vessel. You can be somewhat subintimal and then re-enter and then have that buckling and kinking of the wire. So I love using it, and even for venous access.
Perfect, yeah.
Hey guys, could you tell me what is meant by dry closure?
Absolutely. Chadi, do you want to talk about dry closure? Because I know you.
So dry closure, let's say you have an access, large bore access, TAVR or Impella, and then you want either you pre-close or you didn't pre-close, and you want to make sure that you are closing that artery as a big sheath coming out in a very secure and controlled fashion. So what you need to do is you put 6 or 7 up and over sheath, and you advance a hydrophilic wire. Usually I use a glide advantage that goes around the sheath all the way to the SFA. And then you bring a balloon sized 1-to-1 to the external iliac, or common iliac, usually 7 in women and up to 9 in men. By 40, you inflate it. As you are inflating that balloon that's coming up and over in the ipsilateral segment, you hook up the pressure to the side arm of the large bore. And you notice and you keep attention on the blood pressure. If the blood pressure waveform flattened, that means there's no flow anymore. At that time, you can take the sheath out, do your per close in dry fashion, or if you didn't per close, maybe you can advance a 035 wire and do a per close also in a dry fashion. When you are done with that, securing the access, then you can slowly deflate and see if there's any bleeding happening. And finally, you take a final shot with DSA and ipsilateral view to make sure that you achieve hemostasis.
Thank you. Dr. Alraies, Dr. Tayal, do you have a preference for per close versus MANTA or another closure technique for the calcified access site?
So I'm a big proponent for the use of per close, and partly that is cost-based. But also it's a very tactile and very reliable device that still allows you to have wire access. So when you initially deploy a per close in pre-close fashion, you should have a pretty good sense of the feel of how that it feels, and if it takes, in most instances it will capture relatively well. In the event that there's still some bleeding, or let's say the per close fails, if you're using this dry balloon or dry closure technique like Chadi was describing, the rates and the ability to control that bleeding very, very quickly and still having wire access gives you bailout options to either decide whether you would like to use a secondary per close or then switch to maybe an Angio-Seal or something like that. MANTA is a very exciting technology. We haven't had a tremendous amount of experience with it, again, based strictly on its limited availability because of cost. I think it's something that they are now working on in terms of finding a way for late use, because right now it's meant when you're getting access and putting the device in, there's a depth guard in order to measure where it needs to be deployed in order to have hemostasis. Doing that post closure or after the fact, if let's say an Impella has been in place for 4 or 5 days, is somewhat more challenging. I think people are working on different ways, whether that be with ultrasound guidance or depth assessment in order to do that, which I think would be a much stronger position to use it in. But there are a number of techniques and I think other devices that are slowly coming to market too for large bore closure.
Absolutely. I would share the same thing with you, Raj. And the best situation is when you have TAVR cases, because you are already aware of how healthy the femoral axis is going to be, if it is calcified or not. And I want to make sure I'm getting the ultrasound myself with ultrasound guidance, so I'm sticking a healthy segment if I'm using MANTA. And for something that's going to be staying in, like say for shock patient or emergent, definitely per close is superior.
The other comment with regards to dry closure is I know that there's been a number of papers that have been published looking at the overall rates of vascular complications associated with large bore access and closure. And these things, initially were in the 16% range, and with time have still remained in the 14% at least range when you look at all comers, whether it be with PVADs, TAVR, EVAR. So the rates are still relatively common. Routine use of this crossover balloon occlusion technique or dry closure technique, we just wrote a paper looking at ipsilateral dry closure where you put the balloon and the 035 wire through the actual large bore sheath, especially for SHIP technique cases, basically reduces the rates of bleeding to 5%. So I think that is a very large and statistically significant thing, and something that most people should consider implementing in their practice, although I think a lot of us have gotten a little bit leisurely about some of this stuff. Having the ability and the knowledge how to do it, I think, is very, very important to get yourself out of a GM.
Absolutely. We routinely use it for large bore. At least we cross the wire down beyond the access point for the large bore sheath. So in case we need to advance a sheath up and over is fine. Otherwise, we stay in the IMA and the wire in position from the other side.
We do that relatively routinely, particularly when there's a lot of calcification or some concern with regards to the access point. With TAVRs and things like that, we've kind of gotten away from it just because our cadence has become relatively streamlined. But I do think that a lot of people should consider it and kind of be familiar with it at a minimum. So kind of just continuing on with this case. So basically we have a 6 French sheath, which we put in somewhat low and then started treating the vessel as we go forward. So we kind of shocked and went throughout. And then again, you can see our Impella sheath and dilator advancing throughout that iliac segment from the common femoral without any significant resistance or issues. Of note, in this instance, what I did do is after the 6 French sheath was inserted, and we used Shockwave, I then upsized to an 8 French and then used 1 perclose only to pre-close this arteriotomy. Again, because I was concerned about the luminal diameter of the common femoral.
And obviously you removed the OM4 and put a more heavier wire, maybe Landequist or Supracore.
Yes, we like Supracore when it's available. It's a very nice wire. It's relatively safe. It's efficacious. Or you can even use the Oscore wire from the Abiomed kit too. That's relatively supportive. So from here, we went ahead, we put our Impella CP across the ventricle. I think a lot of people should be familiar with the fact that most Impellas will go across aortic valves that are severely stenotic up to 0.4, usually without a lot of resistance or finagling. However, in some instances, you may need to do a balloon valvuloplasty ahead of time. Because this patient had so many different comorbidities, was somewhat shocky to begin with, in addition to having significant left main disease, proximal right disease. After we had the Impella in place to support him hemodynamically, I went ahead and did a single access BAV through the Impella CP sheath, just to give him some more breathing room. So this is the balloon, and it wasn't a very aggressive BAV. This is a Tayshac 2 balloon, but again, just enough to kind of alleviate him and improve his cardiac output in this scenario. So after doing the BAV, we engaged the left coronary circulation with a guiding catheter and then start off using a rotational atherectomy of the left main into the LAD. I think the fellow was kind of a little slow getting the rota out. So we do rotational atherectomy of the left main and LAD. We leave the circle alone. However, you can see after the rotational atherectomy, there is some plaque in the ostium of the circumflex, which we analyzed under ultrasound. So we went ahead and did a DK crush of the left main and LAD with a very good angiographic result there. And then proceeded to go ahead and do rota and PCI of the right coronary. Now, it's interesting that despite rotational atherectomy here in multiple runs, you can see the balloons at high pressure are still having issues fully inflating around this chunk of calcium. We used a Wolverine balloon, which did result in a little bit of a dissection. So we ended up putting another stent just to still that, but still ended up with an acceptable angiographic result here.
Beautiful.
So at the end of the case, the guy's hemodynamics were relatively stable throughout. We decided, just based on his peripheral vascular disease and not really wanting to get antegrade access and risking limb ischemia, to go ahead and withdraw the Impella device after watching him in the lab for a little bit. So what I did is I removed our large sheath and deployed the 1 perclose over the 035 wire, and then re-advanced our 6 French sheath into the arteriotomy to take an angiogram and make sure that there was no iatric dissections or issues of the common femoral. And from there, we moved to using a Minx vascular closure device, which is not the greatest device, but it is good because it's completely extravascular. So it's kind of like, glorified manual hemostasis, but we're not occluding the lumen of the vessel. So it's a relatively safe device, in my opinion, to use utilizing a modified technique where we put a little bit of contrast in the balloon and watch the balloon come back to the arteriotomy under fluoro, so that you're not fooled in the setting of really calcified disease. And we deployed that, and the guy went home without issues.
So you cinched the knot for the perclose, but not tight enough, just enough to hug the 6 French sheath.
Correct.
And then you advance the perclose through it.
Well, we put the Minx through it.
Minx through the sheath, yeah.
Exactly.
Well, this is a great technique, but I think for people who are starting doing calcified common femoral, Do you recommend to stick with 2 percloses or 1 perclose? And then especially this hybrid maybe can be a challenge for startups.
Of course. And you have to weigh the risks versus the benefits and what you're comfortable with. We've done probably, I think, 1,000 of these modified MINX cases so far, which we published. And then we've done a fair amount of work with large bore access in terms of the hybrid closure technique. So this is something that we do relatively routinely at our institution. But I think even having 1 perclose and a little bit of extravasation and holding some manual pressure there is certainly a reasonable alternative as well.
Not to completely shut the disease artery. Yeah, yeah, absolutely. Great.
All right. Great. So I think in summary, basically, IVL is something that should be considered as most people's primary alternative access strategy. And there's a number of benefits. I think although there's a number of alternative access strategies that have been well defined and described, a lot of them are limited by learning curves. Some of them require pretty extensive pre-procedural assessments, not all of which we have time and availability to do depending on the patient's clinical situation. And there are risks associated with everything that we do in clinical medicine. So really weighing the benefits versus the risks is something I think very, very important for all of us to consider. And when you look at this is something that's really safe, it's easy, and it's quick. So this can be done in the setting of cardiogenic shock, it can be done in the setting of staged high-risk PCI, or even in staged fashion, if you don't feel comfortable doing it quite this way.
Absolutely. And as you pointed out, Raj, is for somebody like transfer, like this patient sick with valve and coronary disease, it's very important to get everything done in one setup, then keep bringing back and forth to the lab. And you did close him at the end after revascularization. So most likely his hemodynamic improved, especially with the BAV. And so that's another feature that during this time of COVID, when we want to decrease the patient's stay in the hospital, as well as coming to different services inside the hospital, is to get everything done in one setup, which is a great illustration by this case.
Thanks.
Melissa, do you have any questions from the audience?
I do. Do you have any damage or worry about damage from using IVL for a long period of time?
Like if being inflated for a long time, I'm assuming the question is. I believe is, I'll take that question, Raj, and we'll see what you comment as well. Is I believe treat IVL once you go to subinflation, which is 40 millimeter, and you deliver in therapy. At that point, the chances of you having entimal or dissection or perf is very, very low, because you are not causing any barotrauma to the vessel. Rather, you are delivering pulse pressure waves that goes through disease as well as healthy segments of the artery. When you go to 6, which is the nominal pressure, it's like any other balloon. You are just causing inflation of the balloon to push the wall artery. So the chances of, and my plan, most of the time I stay for 3 minutes, typical to any other peripheral intervention, and then I go down. From our experience, we never had any issues myself, especially in calcified arteries. But the recoil is very low and phenomenal to the level like it's the vessels stay open because you did do Shockwave there. Any comments, Raj?
No, I agree. I think from a clinical perspective, the risks are very small. And I think it's just about developing some degree of familiarity with the device. I think making sure that the device is actually across the stenosis, that you're on the wire, and really realizing where the main focus of energy is coming from the central emitter, and kind of making sure that you have overlap or key mechanisms there. With regards to prolonged inflammations or risk for causing damage, I don't think there's anything been reported or that I'm aware of acutely.
Absolutely. Yeah.
Thank you, guys. What happens to the debris from the device? Is there any risk of embolization?
That's a great question. And that's actually where it's completely different than a lot of the atherectomy devices, right? Atherectomy devices, by their very mechanism, are debulking devices, which tend to follow biases on the vessel segments where there's tortuosity. This, by design, actually fractures calcium, so it's not debulking it. So it's able to affect both the intimal and medial segments of the vessel. So it doesn't dislodge or displace anything. So in theory, there should be no distal embolization whatsoever, which gives it very, very appealing uses in some off-label categories, which I won't discuss quite yet. But I think that there's a lot of applicability here, especially in critical limb ischemia and some of the other vascular beds.
Other questions, Raj. Is there any concern with post-dilatation with something larger than 7.0 IVL catheter if the reference vessel diameter is larger?
Not at all.
Not at all, yeah.
So, you know, of course, if you go super aggressively with anything, you're going to cause a dissection. But I think once you've fractured the calcium, you'll see that the rates and the rates of dissection, the rates of perforation are going to be much, much lower, significantly lower, as has been demonstrated in some of their previous studies.
Another question, which is also interesting, is if the reference vessel diameter is larger than 7.0, is there a benefit to using IVL since the largest catheter, balloon catheter, is 7.0?
Well, the reference vessel diameter and the intimal vessel diameter are really two different things. So it depends on how bad the disease is and what the diameter is in the disease segment. You know, if it's a 10 millimeter vessel, but there's a stenosis that brings it down to 5, certainly using 7 is more than appropriate. If it's a 10 millimeter vessel and the disease only brings it down to 8, I don't know if you'll really get that much of a benefit because, again, the major mechanism is using apposition. Some people have put 2 balloons to try to press the balloon up against it in the setting of getting more intimal contact. That's obviously off-label and, you know, a little more involved, but you know, you have to wonder what you're trying to get through there if you can't get through an 8 millimeter or 7 millimeter vessel in regards to large bore access, you know, by itself.
Absolutely. Is there a burden of calcium that deemed to be too much for Shockwave would rather go alternative access because IVL will never go through or never work?
I don't think so. I think sometimes you may have to use some adjunctive therapies because these do tend to be a little bulkier in terms of the balloons themselves. Delivering them over 014 wires can be challenging, especially if you're trying to push it up and over the aortoiliac bifurcation. So sometimes using atherectomy, whether that's rotational atherectomy or using a smaller peripheral balloon like a 4.0 something, just to make a little bit of a tract, something that has a very low profile, prior to delivering it is certainly a reasonable strategy in those settings.
Yeah, as a matter of fact, the more calcium you have is maybe you're going to have better result or better efficacy of the device because that's where it works. It needs calcium and that's what make it advantage to other straightforward standard balloon. Okay, we had a couple of questions related to accelerated access. Maybe hopefully we'll cover this at a different time just to and one last question related to imaging. Do you prefer OCT or Ibis with IVL for clinical efficacy? I'm assuming this is for coronary use. This is kind of off-label. There's clinical results of the Disrupt CAD3 coming up at TCT. Stay tuned for the results. In terms of imaging, maybe we'll have more information also from that trial as well and to see what the patient had received during that trial.
I will briefly say, just in reference to that comment, OCT is awesome because you see a lot of very, very cool images. You can actually see fracturing of the calcium, whether that be in the, you know, in whichever vascular bed it is. But, you know, in the periphery, we're limited to using Ibis most routinely in order to determine vessel diameter and luminal gain.
All right. Okay, maybe I can go through my case really quick. Thanks so much, Raj. Really great cases. I cannot stop asking questions. I don't want to interrupt you a lot, but for the sake of time, I kind of took it easy. But the audience asked all pertinent questions. Melissa, do you think we have time for one more case? Or if there is more questions, I would like to take more questions if they are available.
Oh, go ahead, go through your case.
All right. All right. Can you log out, Raj, so I can take over? Thank you, sir. All right. Thanks again, Raj, for a great case. I'm going to go through a quick case, a kind of emergent use of IVL. This is a 56-year-old male presented during COVID time, several days of chest pain, pressure, shortness of breath, and edema. He has multiple comorbidities, as you see there, low EF, 35, has an AICD and PAD. On arrival, he was kind of in the low hypotension, tachycardic, and physical exam suggesting that he is cold and wet, suggesting cardiogenic shock. This is his initial EKG from emergency room. You see ST depression in the lateral leads and slight elevation in AVR. Initial angiogram, as you see on the left panel, is RCA CTO, has a kind of stents from the prox to distal, but it's a flush occlusion. On the right side, there's 80% disease in the circ and also 100% occlusion of the LAD, also in stent stenosis. Again, this is the more illustration of the stump of the LAD. So his MAP was 60, cardiac index was 1.2, CPO 0.23. We do hemodynamics usually on these patients quickly if he was on levofed, so he was kind of tolerating that. And then we went ahead with proceeding with mechanical circulatory support. But as you see here, after getting a micropuncture access on the both sides and using a 4 French catheter just for testing to see if we access correctly, as well as to assess the healthy nature of the vessel. There's diffuse disease in both iliacs, internal and external, with the tortuosity. Distal aortogram will show that more detailed. There's an ostial left common area stent that is recently placed, but as you see, there's a heavy calcium and the other iliac. So again, this is when the Shockwave came into handy. It's very portable. It comes with it's a chargeable generator. It's a mobile. You can put it anywhere on the side of the table. As a connecting cable and the IVL catheter of choice. As Raj mentioned earlier, and our choice as well was a 7.0 balloon that our size 7.0 by 60. It has 5 emitters that actively deliver energy. This is a chart. I mean, you can see it on Catalyst that it's a blog by Shockwave IVL as well as on Shockwave IVL website. You can see here anything from 6.5 to 7, and 7 comes in preference for 7 French. Anything below can go through 6 French, and S4 is specifically for below knee, which is beyond the scope of this case. So again, as you see that we advanced the balloon, we inflated, you see an eccentric calcium in the internal iliac that preventing this calcium to open up. But as we are delivering therapy at 4 atmosphere and delivering therapy, we deliver a total of 3 therapies, meaning 1 pulse per therapy for each treatment is 30 times. And then we did that 3 times, which is 90 pulses. And the medium here is half calcium, half contrast, half saline, which is served as a coupler to facilitate energy transmission to the wall. This is over the course of time, multiple fluorosaves, just to illustrate how the calcium getting pushed away from the wall and how eventually the balloon fully expanded due to at 6 atmospheres, suggesting that the complete calcium is kind of in the media and intima has been cracked. This is a pre and this is post therapy. You see it's more straightforward, was easier to advance the mechanical sheath. Just one thing I would like to highlight, this is a video from Shockwave IVL YouTube. You can see it as well and use it for future. This is, I think, the best way I have seen to illustrate eccentric versus concentric calcium. And this is how IVL is superior because it does deliver therapy 360. However, it does not affect any healthy segment of the artery and just work on the calcium in eccentric lesions, causing the more therapy delivered, the more cracking happen. As Raj mentioned earlier, and the above knee and 7.0, you have 300 pulses, meaning you have plenty of therapy to deliver in that space, especially if you have time. Again, this is showing the final angiogram and eventually advancing the Impella sheath with no problems. Again, this is a standard work, putting the Impella in, wired with a workhorse wire, and then eventually ballooning, Ibising. It was a big vessel, and eventually put it a new stent inside, just distal to that. Final result showing TIMI3 flow, and his hemodynamic was still requiring some levofed. Therefore, we kept the Impella in for 2 days and eventually removed the impella and the sheath, and the patient had no recoil in the iliac space and was discharged with no peripheral ischemia and EF of 40%. So again, to reiterate what Raj already mentioned is this technology is safe and easily incorporated in a standard flow of work. It's similar to any iliac ballooning, except that deliver way more sophisticated therapy to the vessel, calcified vessel. And it facilitates lesion expansion and adjunctive for other therapies. If you, as we mentioned earlier, if you go to 8 or 9O balloons, it's fine. Go ahead, specifically if the artery is bigger lumen. In terms of sizing, just one comment is you always go 0.5 size above. So if you think that your iliac is 7.0, use 7.5. If you think it's, again, it does not require proctorship. It's nice to have at the beginning to have a vendor around to show you how to connect, how to do the connections and the sleeves and so forth. It improves resources utilization and patient disposition among high-risk patients. And again, given the fact that we are in the COVID pandemic, it does expedite patient hospital stay as well as transit during their complicated course, especially in one-stop shop for these cases. With that, we'll stop. If there is any questions, Melissa, that came across.
That was a great case, Shadi. Great demonstration.
Just one question. How much time is added or removed by using IVL?
Well, it depends. If you have a complication, then you've saved a lot of time and a lot of money. You know, the average cost of really prolonged hospitalization, blood transfusions, a blood transfusion alone in the United States is $6,800. So if you can get away and avoid needing a covered stent or avoid having any kind of dissections or perforations, I think you've done a great service. In terms of speed, I mean, typically it's as quick as getting a 6-inch sheath, advancing a balloon and inflating it. As Shadi pointed out, in terms of the cadence, you're looking at basically 30-second inflations, which you can perform up to 10 times. So I really think that being thorough and treating it when you have the ability to do it is probably the most advantageous approach. But if you have time, then you can take, you know, 3 to 10 minutes, you can take 5 minutes. It's very, very quick. And I think there's been a couple of papers highlighting its efficacy in cardiogenic shock, as Shadi demonstrated as well.
Awesome. I have one last question. Have you ever staged IVL iliac treatment prior to TAVR procedure? If so, why? And your thoughts?
Stage it means treat it and then bring the patient back for TAVR? There is no, I think it's doable, but I don't see the point of doing that since you can treat and have your pathway open for the large sheath. So, and that's the beauty of IVL Shockwave, is that it allows you treating in ad hoc and on the same setting. And you don't need to bring the patient back unless you are doing other work in different peripheral space, and then you want to bring him for TAVR. But if it's the only thing is opening a pathway to the TAVR, I think it should be done at the one setup. What do you think, Raj?
You know, I think you can certainly consider doing that in terms of, you know, it might be a little more advantageous from a billing perspective and separate procedures, especially if you're going to go ahead and have femoral access to, let's say, do coronary revascularization or something prior to TAVR. Although studies have shown that multiple procedures in the elderly kind of add to a cumulative increase in the overall risk benefits. So we typically try to do everything as a one-stop shop. But I think it's really dependent on the operator preference and comfortability level there.
Absolutely.
Thank you, guys. We're going to go ahead and bring this to a close. We'd like to thank Drs. Alraies and Tayal for their participation, and thanks to you all for joining us. This will conclude our event.
Thank you.
Thank you, guys.
Thanks for joining us. Bye-bye.